we would like to welcome Nova Adams, who is a educational liaison from Madonna Rehab Hospital. She holds a bachelor's degree in speech-language pathology and a master's in special education. She's worked in the public schools as a speech-language pathologist and has been at Madonna Rehab Hospital for over 25 years, working as a teacher in the Therapeutic Learning Center and as the educational liaison at Madonna, working with schools, parents, and kids in planning for school reentry after a student's illness or injury. She is also accredited as a brain injury specialist through Access. So I would like to welcome and thank Nova for presenting this webinar today.
All right, well, hopefully all of you can hear me. I'm Nova Adams, and as she said, I'm the educational liaison at Madonna Rehab Hospital. Madonna is a full-service rehab hospital. We have all areas. We have adult programs in traumatic brain injury, stroke, spinal cord injury, and the area I work mostly in is in the outpatient area and also in our Alexis Virgil Children's Rehab Hospital. And it is an acute rehab program. As you know, I mean, we understand that traumatic brain injury is, more people are surviving. We're seeing more of these kids go back into the school setting, and I think that's the important thing about, the education for our school personnel is that these kids do go back to school. Each year there's an estimated 1.7 million people who sustain a TBI, and in those age groups 0 to 4, 15 to 19, and over 65, they're the most likely to sustain the traumatic brain injuries. Over 500,000 ER visits for that 0 to 14 age group in a year. 75% of those are mild TBIs and concussions. So we're going to spend most of the people and most of the students we see in our setting, in our rehab hospital, are going to have moderate to severe, brain injuries. So I'm going to be talking about that group of people, but a lot of the things I'm going to be talking about are very applicable to our mild TBIs, our concussion, our kids with concussions. And I think, with all of the publicity out there, we're seeing more and more of those kids every single day that are demonstrating difficulties at school and that type of thing. So just, keeping in mind many of these same, strategies and modifications and recommendations, can be also applied to those kids with those mild injuries. And as this is from the Centers for Disease Control, the leading causes of brain injury, I'm sure you're, aware of these: falls, and motor vehicle traffic, unknown or others struck by or against, and assaults. Interestingly enough, in Nebraska, we do verifications of other health impaired, traumatic brain injury, those types of things. We're seeing a huge increase in encephalopathies, viral encephalopathies, sinus infections that have gone bad. We are now seeing this influenza A hit some of our kids and cause some of the cognitive and physical problems, related to that influenza A. So, just, a rise in those areas also. So we really have to adjust, what we think of as a TBI, but, these kids exhibit a lot of the same kinds of deficits as those kids, with true traumatic brain injuries. So just kind of an interesting thing that we're seeing a lot more of the viral encephalopathies now for some reason. Now, I'm speaking to our process, what we do, as far as our students go. Other hospitals may do some similar things, but I'm going to just talk about, the way our process that we use here. Now, when a patient comes to Madonna, Most of the time they will come from an acute care hospital. So they've been in the acute care hospital and been stabilized medically. At that point, when they are stabilized medically, they would transfer to Madonna. Now, that doesn't mean to say that we, don't have kids. We have kids that come to us on vents. We have kids that come to us that are still in comas. We have children come to us that are still very agitated and nonverbal and all of those types of things. They come to us at a very low level. But as far as medically, they're pretty stable when they come to us. They don't need that acute care setting at, the time they come to us. On our pediatric team, we have a physician. We have a physiatrist hired by Madonna. That's a Madonna doctor. And then we also have pediatric doctors that work with our team also. We have nurse practitioners. Of course, they're used to evaluate the medical needs, including pharmacology, writing referrals, those types of things. A physiatrist is a doctor, a rehab doctor, that really understands that process of rehabilitation. We have psychologists that is with our team. The psychologists, they work with the families, they work with our patients, and they also help, they assess the cognitive and psychological symptoms. They look at risk factors for these kids, and, they do behavioral plans with our team. We use the psychologist on our team in many different ways. Of course, we have a physical therapist on our team. They look at the postural stability, agility, vestibular concerns, the walking, the balance, all of those types of things. We also have, of course, children that have spinal cord injuries on our unit, so, they work on those kinds of things too. We have occupational therapists who assess the factors that may limit the full return to daily activities. And a lot of our occupational therapists will also look at vision. Many times our students that come to us with traumatic brain injuries will have vision difficulties. So we also have on staff that, serves our hospital, a neuro-ophthalmologist who can look at that vision and assess vision, work with prism glasses, those types of things. So, the occupational therapist and that person work very, very closely, because a lot of our students, as I said, come to us with a significant visual perceptual kinds of difficulties. Not so much acuity, although that does happen once in a while, but, the visual perceptual types of things. And we'll talk about, how that affects our students a little bit later on. We have speech therapists on our team that really do assess the functional capabilities related to communication, the cognitive communication, their cognitive status, particularly related to executive functioning, organization, planning. We'll have our students that have, some language difficulties like aphasias and that type of thing due to the traumatic brain injury, so they cover all of those types of things. They also do feeding and swallowing, because many times these students will come to us with feeding and swallowing issues, that type of thing. We have case managers and social workers, and they kind of coordinate our cases for us. They work with outside agencies and the parents and do a lot of work as far as, discharge planning. Is the student going to need outpatient therapies when they're done here? Medicaid, Medicare, waiver programs, all of those kinds of things. They help the families understand and go through that system. Then we have myself, the educational liaison, and I'm really the person that coordinates all the communication between the rehabilitation center and the school staff, and I should have put and the parents on there, because they're a very, very big part of the whole planning, and the patient themselves, because when you talk about you know, our pediatric population, we are usually talking up through high school. So many times, you know, our high schools are really, high schoolers really like to be a part of that planning and let us know what they would like to see and not see when they go back to school. Also, I didn't mention it, but we also have recreational therapists on our staff that work with our students. Most of the kids that come to Madonna and they're in our acute rehab setting or our pediatric hospital here will get 3 hours or more of therapy a day. So their program is pretty jam-packed. Usually they're seeing the physical therapist for two treatment sessions a day. The same with OT, the same with the speech and language pathologist. They may have recreation therapy. They may be seeing the psychologist. And then we're very, very lucky here. We have what's called a therapeutic learning center. And what it is a classroom within Madonna. And it's like a one-room classroom. We serve all ages, and that's another part of what I do is I am the teacher, one of the teachers in the classroom, and then I'm also the educational liaison. But our TLC is completely grant-funded, so there's no charge to any of our students. But the reason we began the Learning Center or the one-room schoolhouse is we realized early on that these students were going to be going back into the classroom setting. And we really needed to mirror, you know, that classroom setting for those students, you know, going back to school. So that's why we started our TLC classroom. It was for those students who, you know, will obviously be going back to school. And we can, you know, work on those skills that a student is having difficulty with, but not only work on those skills, we can also kind of do an assessment as far as what is it going to be like in the classroom setting, what is their attention, their memory, all of those things, how is that going to impact them when they go back to school. My role as the educational liaison would be really to coordinate communication with the school. Also to communicate with the student's family and to provide education regarding that school reentry process, you know, including the IEP and 504. We have to remember that most of these kids that come to Madonna have never been served by any type of special education services. These families are not familiar with these services at all. You know, and it's kind of, you know, my job would be to, you know, teach them and give them an opportunity to learn about what can the school, you know, provide when the student goes back to school, kind of help them through that process of, you know, just starting to talk about verifications for special education. What does that mean? What does it look like? You know, those types of things. What kind of paperwork do we have to fill out? You don't know any of that kind of information that we can start giving the parents. We also have to keep in mind, you know, it is a process. You know, these parents have a lot on their plate. Excuse me. You know, and this is a new injury, you know, and they're just working through that whole process of, you know, that their child's injury. And so we, you know, it's a process and it's a learning, there's a learning curve to it. So, you know, we begin that process early on. But we really provide education to our parents throughout their child's stay, you know, and helping them prepare for what does it look like, you know, as far as when the student leaves Madonna. You know, because if we think about it, you know, the parent is really going to be that bridge from the rehab hospital to the school. You know, we do a lot of planning, but we want the parents to gain enough knowledge and, you know, be able to work through that process and know the processes for that return to school, that they can really help the school, you know, with some decision making too. You know, maybe some initially, but even, on down the line, 6 months, 8 months, 12 months down the line, really provide education to the parent as far as, traumatic brain injury, its effects, and what are some of the strategies and learning opportunities that can be provided to the student to help, their child. So we really do a lot of education with our parents. We also, as an education liaison, I provide the school with the necessary documentation. When a person or a student first comes to Madonna, I provide the history and physical that the doctor, writes out. It talks about the diagnosis and the effects on the student's cognition, their physical, status, their sensory status, hearing, vision, those kinds of things, and the social emotional. So, and then we also do a checklist. Our therapists do a checklist, and we'll get to that checklist later, and we'll look at that. But our therapists provide that, they do a checklist that talks about where is the student at, in those 4 domains, and I provide that to the school. And then, of course, the release of information, I provide that to the school. The other part of what I do is just arrange for that transition planning between the family and the school and the Madonna personnel. That just really means, setting up, how do we want to do this? Do we want to do a teleconference meeting? Does the school want to come here and observe the student? That type of thing, and just really starting to plant that seed in the school's, head as far as, okay, how are we going to plan this transition from the rehab hospital to school? I obtain the formal evaluation protocols. Let's say the psychologist does, testing, speech and language pathologist does testing, sometimes there's vision tests to be given, and I obtain all those evaluation protocols and reports and forward those to the schools. And I assist with the school meeting, which is between Madonna personnel, the school, and the parents, and possibly the patient. And then I also am involved in the plan for the follow-up. Many times when after our patients are discharged, they will come back and we will do re-evals on the outpatient side, and they'll have a re-eval by the physical therapist, occupational therapist, speech and language pathologist, the psychologist, the doctor, and myself. So we can, just check and see if they're still progressing, what are their continued needs, those types of things. And we talked a little bit about this, already, the process I use. The first thing I do is I obtain that release of information so I know it's okay for me to be, communicating with the school. And before I even do that, I really like to sit down and make a parent a part of that, and just talk about the process. Let them know, listen, I'm going to be calling the school and talking with the school, about your child. Is there a person you would like me to be talking with that you feel comfortable with, that you trust within the school, and, at this point I may begin some of that educational process for our parents, begin talking about, well, many times our students that leave here will require some, specialized services, because, helping the parent understand, what, they may not be at the end, completely healed back to themselves by the time they leave here. I think we all know that, an important thing to keep in mind is, with insurance and the way it is now, we're seeing shorter and shorter stays, at Madonna. Years ago it would be that a student could stay here for 6 months, so a great deal of the recovery was happening within Madonna. But now the way insurance companies work is like, what, if a student is able to transition to that next step, which would be outpatient medically based therapy, their stay at Madonna is much, much shorter. So very seldom, I mean, usually a person's recovery is just beginning when they're at Madonna, and these kids are going to be transitioning back home and back into the school setting much, much earlier than ever before. So really, starting that process right from the, when they get here at Madonna, and educating those patients, those parents, but also then getting a hold of the school so we can begin, that whole process. I like to just sit down and talk to my parents, or, here are some various options for going back to school, and we just talk about it. Maybe your student will be able to go back, for a half a day. Maybe your student will be able to, take a couple of social classes. Maybe your student will be able to go to a few, regular, core classes. Just really starting to brainstorm a lot of the options that are available at school, because these parents, for the most part, have no idea, again, what schools can do and what kind of programming, that they can provide. So really just starting to brainstorm a lot of that with our parents. And then making sure I obtain verbal permission to discuss the student with the school personnel. And all of my parents are always like, yes, that would be fine, Then I go into that initial school communication, and I like to identify the person at the school who will be the contact person for future communication. And as it's a different person in every school. Sometimes it's a guidance counselor. Sometimes it's the vice principal. Sometimes it's your principal. I really try to connect with the special education director, because I would say most of the time, I would say 75 to 90% of the time, our kids will go back and receive special education services in some respect. Whether it be for OT, PT, or speech, or resource services. I mean, there's just a whole array of options, and I think that's, just a really important thing for schools to recognize, is that they really have to be open to some, some different types of programming for these kids that go back. Just because they can come back at just such varying levels, and their needs can be so individualized that, they don't necessarily fit into some pre-designed program that the school already has. We have to be very creative with our programming, when we're talking about going back to school. And we'll talk a little bit about that more. What I like to do is discuss what the patient's injury is, its effects, what is their medical status, looking at the physical, cognitive, sensory, social, emotional effects of the injury. I like to talk about the time frame. When our patients come in, we do an evaluation. All of our therapies do an evaluation, and we meet as a team, and we develop a set of goals, and we design a timeline for when we think this student will discharge. And, we then communicate that time frame for discharge with our schools. Like I said, we begin planning for that school parent Madonna meeting. At that first communication with the school, I want the school to be thinking we need to have a school meeting, and I try to give the school, an idea of personnel that should be at the meeting. Does it look like we're going to have an occupational therapist, a physical therapist, the speech and language pathologist, special ed teachers, vision people. I like to try to give them an idea. We probably want to be involving these people, and I know I work with the area education agencies all the time, and I know some of them, I work a lot with the ones in western Iowa, and they have, the brain injury teams there, so kind of connect with them and really use those teams to help not only with that transition, but also then they can kind of take over with that education for school personnel. So, really using, some of the resources that are already built into your system. At that time then, I like to fax that history and physical, that initial skills checklist that I'm going to be talking about and looking at, and that release to the school and to that person who's identified as my contact person. Okay, going back again to preparing that parent, providing them with lots of education. We do this throughout their stay, looking at how this injury is affecting their return, going to affect their return to school. Looking at all those things, the cognitive, the academic, the physical, and as we get closer to the time of discharge, really sitting down and talking with the parent, really we're seeing difficulties in these areas. Our psychologist does neuropsych testing, so we can really see, we have real deficits in the area of memory. We have deficits in the area of visual processing, in processing speed, and really sitting down and talking with the parents about, what those deficits are and how this is going to return, affect their return to school. And for each class, we'll, giving them, for instances, in the English class, if they are having vision problems and their vision, is affecting their reading, or their reading comprehension is decreased, or even math and those types of things. So really, trying to educate the parent, this is where we believe your student is going to be at, when they're done with their rehab setting here, and really helping them understand this is not the end point. This is just the beginning. You're going to continue to see huge improvements, as time goes on. I mean, these kids, continue to improve 6 months, year. I've seen kids even improving much longer than that. So, talking with the parent about what the academic expectations may be initially. What kind of supports is this student going to need for success? What support systems are available at the school, because I'll sit down and really talk with that contact person and kind of see. It seems like each school has their own personality, so it's my job to kind of figure out, well, do they have a pull-out resource time? Is everything inclusion? What can the school provide, and helping the school understand how can they provide some creative programming also. Helping the parent understand what's the difference between medically based and educationally based therapy, and helping them understand that. Also, and the time frame. We're talking about what kind of time frame are we talking about, going over that with the parents. Just a moment. Hello? I can't talk right now. I'm sorry. I'm in the middle of something. Sorry. I'm sorry. I wanted to make sure it wasn't somebody from your end that our webinar had gone bad, so my apologies. As far as preparing the school, again, I update the school designee, once a week, once every 2 weeks, whatever we agree upon as far as, what the patient's progress is. This is how they're progressing. Talking about, some of the parent preferences. One of the number one things, you can imagine, one of the number one things I'll hear from parents and I'll hear from the student is like, well, I don't want to be in special ed. I don't want to be pulled out and look differently. And so the way I have to really provide them with the education that will help them understand, the options for school and, where their student is at this time and how we can use those services at school, and those special education services. And sometimes, I'll explain it to the parent gets it, but, the student's not at a level where they have that understanding of, what their deficit areas are, and they can't process that, so, I don't explain it necessarily like you're going to be in special ed. We really provide, we're going to give you some specialized assistance at school, really so you can go back to school and be very, very successful. And I said it may, and I may tell them it looks a little bit different than, what you normally would do, but this is to help you get better, and really starting, from that point of view. And just, again, looking at that projected discharge date and identifying that school meeting and time. When we do that school meeting, the people that can be there on the school end of it is like the special education director, occupational therapist, physical therapist, speech and language pathologist, nurses, teachers, psychologists, resource personnel, administration. Over in Iowa, your area education agency personnel. I think they many times are the OTs, PTs, they come from there. But if you have a brain injury team, asking your AEA, if they have a brain injury team, that can be there, that can assist with, some programming. As far as Madonna personnel, we have the nurse there, the SLP, the occupational therapist, the physical therapist, psychologist, the liaison. Sometimes our case managers will be there, but, most of the Madonna personnel will be there, and, of course, the parents and the students. Okay. During that school meeting, what we really like to provide is, and this will be information that everybody is hearing, the date of the injury. How was this student injured? The patient's medical, physical, cognitive, sensory, social, emotional status upon admission. What were they like? This is where they were when they admitted to Madonna, discussing all of those kinds of things. Talking about this is the date of discharge, and these are the anticipated medically based therapies this student is going to get after discharge, and then taking a look at their current medications. And then, okay, and this is where we get into this checklist, and what you see here is the checklist that we use when we talk about planning for discharge, discharge from Madonna and the going back to school. Now, what I do is when a person first comes to Madonna, our therapist will fill out the first 3 sheets. And you can see what we do is we look at, their motor functioning. What is their walking like? Are they using a wheelchair? What's their balance like? Just so the school can get an idea of where is this student starting out at. So we look at their motor functioning, their sensory functioning, cognition, and those pages will be later on, and I'll move to those. But, we will provide this to the schools initially, so they can really get an idea of how serious this injury is, But we also use this. This is our mode of communication and really helps us for planning for going back to school. And so right before discharge, our therapist will fill this out. So you will know, this is where this student is at as far as their walking. Do they have minimal difficulty? And our therapist will talk about every single one of these, items. Where are they at with their walking? How is their balance? Do they need to have standby assistance? Are they hands-on assistance? Are they going to have to use the wheelchair to ambulate? What is their strength like? All of those kinds of things. Our therapists are going to, talk about each one of these items. What's their coordination like? Do they fatigue easily? During physical activities, or can they walk down the hallway? Do they have the stamina to even walk down the hallway? Do they have sleep disturbances, which are really going to, impact them for their activities during the day? Dizziness, self-feeding, dressing, and you think about those. Okay, well, dressing, how would that affect me? Well, during toilet, can they manage their clothes, that kind of thing. All of those. We will address each one of those and talk about these are the kind of accommodations that the student is going to need. Again, then we have the sensory functioning, visual impairments. Do they have the double vision? Like I said, many of our students will, with traumatic brain injuries, will come to us with double vision. They'll have some sensitivity to light. They'll have difficulty with tracking, with depth perception. We don't see so much with acuity. It's more of that visual perceptual. Will they have a nystagmus where their eyes are moving back and forth very quickly? You know, what's their hearing like? Do they have decreased sensations in parts of their bodies? Because think of a person, many times will, a person with a brain injury will have weakness or decreased sensation, kind of like a person with a stroke on one side of their body or another, They have decreased sensation. Well, could they easily burn themselves? Could they actually, hurt themselves, because of the decreased sensation? Talking about all of those kinds of things. We look at the speech and language pathologist, our occupational therapist, our whole team really looks at that cognition, and the thinking and the communication and, skills. I will say that as far as our kids going back to school, our kids with TBI, slowed process of thinking is probably one of our #1 issues with our kids. Their ability to process information, written information, verbal information, visual information is just so impacted, so much slower. And even for our students who have the milder injuries, that's one of the areas that really impacts, our students. Do our students have memory loss? I mean, if we think about it, if they have short-term memory loss, which would mean, let's say, they learn a new process and they can't remember it 5 minutes later. They can't remember it to go home and do their homework. Even I see our kids with our concussions and mild traumatic brain injuries run into that issue a lot. They'll have it when they're in class and they go to do it later and it's gone. Sometimes we'll see students with very severe short-term memory problems where they can't remember 5 minutes ago what was said. Those were obviously going to significantly impair their ability to go back to school, to learn new processes, new information, those types of things. So really some, creative programming has to be done at school. Many times with our students, we'll see some memory loss of skills that were learned prior. One of the big ones I see is math. We'll have kids that are in high school that are, and they're making a fairly good recovery. They're talking, they're walking, those kinds of things, and they can start coming down to our school, but they have forgotten all their math processes. And it seems to be math seems to be like our #1. We'll have kids that are in geometry and pre-calc, and they've forgotten how to add, subtract, divide, multiply. They don't know how to do fractions. They've forgotten geography. It's a lot of kind of like that Swiss cheese effect. You never know what's going to be affected. I had one little gal who lost all geography. She could do everything else, but she had no idea, had no idea of any of the names of states, where they were, countries, those kinds of things, So we have to look and see, is there some long-term, is there some loss of prior knowledge? Because, when we learn, we use what we already know for that new learning. And if they don't have that base, it's much, much harder to learn that new information. So, taking a look at what have they lost. And we do a lot of review, and in fact, talking about math, that's one of our areas that they seem to recover pretty quickly, and I think it's probably because math is, you use the same processes over and over and over again. But, in thinking about these kids that are up, I had 2 this summer. These were kids that were up and walking, talking, and doing real well. So the insurance company says, you know what, you need to go home. And they lived out in a rural area. And so what their school had to do, because they were still working on, like fractions, and they were supposed to be in pre-calc classes, so their school ended up hiring a tutor that really sat down and just worked over all of those processes, and they also had some difficulty with reading comprehension and the abstract thinking, those kinds of things. So, these students were not ready to go back into the classroom. They were up walking, talking, and, socially doing really well, but academically they were not able to go back into any of their classes and function. So, the school really had to be creative, and they were very, very good as far as being able to provide these students, with a tutor. So new learning again, if your processing is slow, if you have some of that prior knowledge that's gone, if you have poor attention, poor concentration, new learning can be very, very difficult. So, doing a lot of, and we'll talk about accommodations for that. Most of our students will have that impaired concentration, some difficulties with comprehension, and it may be, some of that processing also. We'll have students with traumatic brain injuries that will have an aphasia, and some difficulty with word finding, and not be able to come up with the words, and, some significant language problems, depending on where their injury was in their brain. So, keeping that in mind. Most of our students, the higher level skills, the executive functioning skills, like the organization, initiation, shifting of thought, being able to plan, most of our students will have deficits in those areas, so keeping that in mind when they go back to school, that their planning and their ability to organize and initiate and problem solve through difficult things is going to be significantly decreased. Do they become frustrated, when they can't do something? We really have to watch out for that. Many times I'll say, when these kids go back to school, really we need to have a program where it's no-fail learning, where we don't give them the opportunity to fail academically, socially, physically. I mean, we really push for a lot of structure. Anyway, initiation of thought, rigidity of thought, all of those kinds of things, we take a look at. Most of our kids have no awareness of their deficits, when they go back. They don't understand. They're like, yeah, I can go back into my classroom, no problem at all. And they absolutely would flounder if they went back to classes, So they're, that's pretty typical that they have poor awareness of their deficits. Looking at the emotional, what are their emotions like? Most of the time we have enough structure in our facility that we don't see a lot of emotional outbursts, and if we do, it's probably more toward the beginning of their stay and in their recovery, because that's just kind of one of the stages of brain injury, is where they, are very impulsive and can't process through, the stimulus that's going on, and we see more of the behavioral kinds of things. But usually by the end, they're pretty well managed, but keeping in mind it's a very structured setting, and we don't let things go wrong, for very long. We're pretty much on that. And then what we do is we really talk about with the schools, okay, here are the adaptations and modifications that we're recommending. Is this student going to need, is he in a wheelchair? Is he going to be walking? Can he walk by himself? Can he pathfind? Most of these students will go back and, it won't be the same routines. So are they going to be able to find the new rooms that they go to? Are they going to remember? Are they going to be able to pathfind themselves? Are they going to be able to be in a crowded hallway? Are they going to be able to carry their books? Are they going to have somebody carry their books for them? If they're going to be in a wheelchair, or they have balance problems, are they going to need somebody carrying their trays, their backpack? Are they going to remember their locker combination? Are they going to be able to reach their locker? Toileting. Can they toilet by themselves? Can they manage their clothing after they toilet? All of those kinds of things. Are they safe to, do things by themselves? Will they be able to move around the classroom? Our younger kids, that are a little bit more impulsive. Yes, they may be able to walk very, very well, but if your concentration and attention is poor, they may lose their balance in a classroom just walking around, because there's so many other kids and so many other things going on that they may lose their balance and, not be safe walking by themselves in a classroom. So, really talking about all those things, we try to cover all the bases, as far as what this student is going to need when they go back to school. looking at their school reentry and their schedule. Are we saying part-time? Do they need part-time with breaks? Can they go back full-time? Or are they at such a level where we don't even think they can go back to school at this point and they need to do homebound, just some creative programming. Physical. Most of our kids with traumatic brain injuries probably can't go back to anything that's contact until they're cleared by their neurologist, or let's say they can go back and maybe they can do weights or a certain poundage of weights. We like to look at all of that stuff and kind of guide the school as far as what the student is going to need, when they go back. Looking at the pacing, all of these things. Are these students going to be able to do the things in a timely manner? Like, if we were suggesting they go back into some type of a classroom, are they going to really be able to process all that information from a lecture? And how, a teacher might teach, we put the PowerPoint on the board and the teacher's talking and expecting to have the student, copy down the PowerPoint and listen and process out information and get it down on the paper. Wow, I mean, that's a really difficult task. So really breaking apart all those expectations, almost like a task analysis of what are the expectations, what does a student have to do in this class to be successful, and can they do all those things? And if we can't, we don't think they can, what part is it that's, do we need to look at changing? Like omitting assignments that require them to copy things in time situations like a lecture or something like that. Giving them extra time. A lot of our students, when they go back to school will become, they'll become physically tired. Well, if they could become physically tired, it also impacts their cognition. They'll become cognitively tired. Or even cognitive, even fatigue can cause physical problems. So just being aware of those kinds of things, making sure that we have breaks built in, that type of thing. As far as the environment, do we have a student, a young student who, needs to have the areas defined concretely, or do they have to have planned sitting? Do we need to alter the physical room arrangement so they can stay on task so their attention is good? Do we need to minimize those distractions, those kinds of things? And some of our kids, especially our younger ones, will need to really have those positive rules, for space, those types of things, or even behaviors, a program, behavioral type of program, so they can relearn some of those skills that they may have lost because of their injury. As far as presenting the subject material, really understanding what the student's learning style is. Do they need to have a specialized curriculum? If they, what's their skill? If we want them to do history, can they read and comprehend the history text, or do they need something else? Or maybe a history text that's, what a high school history text looks like. It can be very confusing with graphs and pictures and little boxes of information. Do we need to simplify that, so the student knows this is what is the most important, this is what I need to be looking at. Emphasizing that critical information, as the teacher is teaching. Well, some of these students, aren't able to pick out main ideas. What's important in this lecture, and what's just extraneous information. Can't pick that out. So really, need that, opportunity to hear the critical information, or even just have the information repeated again. Sometimes what we'll do is have a person go to history class, but then, before that class, maybe the resource person will review, this is what you're going to be hearing about in your history class, and talking about it beforehand, or you can, sometimes do it afterwards, doing some of that creative programming. presenting demonstrations, doing lots and lots of modeling if there's a new process. Vocabulary, because of the language skills may be decreased. Sometimes, the reading levels aren't what they used to be. Or if they're having vision problems, think about the vision problems. Can they even read from the book? Does it have to be enlarged? Or can they read from the board and then look down at their paper? Lots and lots of our kids can't do that. Where they look at the board and then they have to look down and look back at the board. That's a very, very complex activity visually. So if they're having those visual perceptual problems, just keeping that in mind. Is this student going to need to be in some individual and small group and have some extra instructions? Our checklist here kind of covers, grades K through, even college. But some of our kids will tape their lectures, or, I'm sure you've probably heard of smart pens. Some of those, are we going to be utilizing some of those kinds of things? Note takers, the materials, the size of the materials, just all of those kinds of things. What kind of equipment are they going to need to be have their own communication device? Or are they going to have their own computer? Or do they need drag and dictate on their own computer? All of those kinds of things. Like I said, most of our students will have difficulties with that executive functioning piece. Keeping organized, remembering what their assignments are, initiating those assignments. So most of the time we suggest our kids go back with, planners, making sure that they have a written backup for any of their assignments. Do they need their assignments shortened? All of those kinds of adaptations, adapting worksheets, giving extra cues, are they able to write, just all of those things. Self-management, again, the planners, is this student going to be able to go back and take tests? Because many times, they've missed material, so they can't take those tests, and their, processing is slow, their memory is slow. So really taking a look at, do we really want to be giving these students tests at this point? I guess what I would have to say is just really doing a lot of planning, and what we suggest is putting in a maximum amount of structure, and having all that planning set up before the student even goes back to school on the first day. Doing a school visit before the student goes back to school on that first day. So, we can get all the hoopla out of the way of, oh, John's back, but then also making sure that we have the program all set up so John will know exactly what the day is going to look like. Because, I had a little guy today, talk about he's extremely anxious about, going back to school and what his day is going to look like, because it's going to be a little bit different, because of his illness. But he's going to go to school, visit the kids, and then somebody at school is going to sit down with him. This is what your day is going to look like. You're going to meet, when you come into the school, you're going to meet with Mrs. So-and-so in this office first. Review what the day is going to look like, and and write it all down so there's no question in their minds, because that anxiety can cause some pretty significant concern for the students, and breakdowns. So we do a maximum amount of structure of planning before these students go to school, and that type of thing. Sometimes that social piece is, difficult. What I hear a lot is, the student's just different when they come back, obviously. So, sometimes I suggest to my school, what, let's get a couple of really good friends that can be a really good support with the student, for this student, and really use them. Provide some education to those, those fellow students that the patient is really close with, and talking, to them, how can you help, so-and-so. Here's what you can do throughout the day, and using some of those opportunities. Sometimes our students will have to go back, and do some, programs that will help, reinforce certain behaviors. But, really I think starting out that motivation and that reinforcement, if we make the program successful, and we make their learning successful so there's no chance of them breaking down from the get-go, I think that is probably one of the things that I see as the most important thing. Making sure that their return to school is a successful return, because you know what, we can always take things away, and take those modifications and accommodations away, but as the person becomes more successful and gets better. But it's very, very, very hard for them to have these breakdowns and let's hurry up and get this into place because he's really falling apart. Let's get him going from the very beginning and take them away gradually, as the student improves. And obviously, IEPs are once a year. You know what, for these kids, they have to be done. We have to meet much more regularly. I usually say, after 6 weeks, 4 weeks to 6 weeks, let's meet again as a team and see, okay, how are things going? Sometimes I like to have a person be meeting with the student in the morning and the evening, especially for our high school students, to see, okay, John, how did your day go today? Did you, what worked well, what didn't work so well? So if there are concerns from the very beginning, we can deal with those, and then that person can also be the communicator with the parent at home. And sometimes we've done communication books, where the teachers will say, John did really, really well, this seemed to work, and then John gets home and then, becomes very upset about something that happened at school and he didn't tell anybody at school. Those communication, the books can, be a communication between the school and the parent, and those work very, very nicely. I'm close to the end here. I have included, and I know you guys have participated in some other, really good workshops, talking about returning to school. I've just included on this, some accommodations, for language, for memory, memory strategies, attention challenges and strategies as we go through. I am not going to go through these because of our, time constraints, but they're there for your use, and I think you've probably talked about some of those with some of the other, in your other webinars. So just in summary, that these students really need to be carefully transitioned into the schools with the support plans already in place before they even start. Some students may need to go back just on a part-time basis, because it's just a full day's too much. Keeping in mind that the families are really that natural link between the hospital and the home and the school, and that they need the full support of the professionals to plan for their child's successful reintegration into school. And I'll add one other little thing here, the transition between, those grades to grade, school to school. I've seen many times that, a student's doing really well in grade school, and then that transition planning isn't thorough enough, and they get to middle school, and all of a sudden they start falling apart. And then I had several, students that happened, and we started seeing significant behavioral issues. So just really that whole process of, planning from grade to grade, school to school, that type of thing. So anyway, thank you so much for the opportunity to do this. And I think, this will be, like she said, available to you for your use.
Great. Thanks, Nova. I appreciate your time today. I will be sending out, as I said, a certificate of attendance for folks who are on the webinar today, as well as a copy of the slides, and there will be a recording of this webinar available. So thanks, everyone, and have a great evening, and please mark on your calendars to join us on February 20th from 3:45 to 4:45. Natasha Retz from the Brain Injury Alliance of Iowa will be presenting on common challenges after brain injury and the Neuro Resource Facilitation Program. Thank you, and have a great evening.